in that glass? Or was it vodka?
You don't drink white spirits, do you know? He's a whiskey man. It's the Scottish, okay?
A white spirits kind of person.
Yeah.
Unless you're in cocktails, but let's not talk about that. So
I'm still doing dry January.
Cheers, guys. Good health. Good afternoon to you both. Thank you very much for joining us today.
Good afternoon.
I'm going to say welcome to everyone else that's in the room, either here in Click Meeting or indeed on Facebook. If you are on Facebook and you're watching us, please do remember that Facebook is a public domain. So any questions that you ask or type in Facebook are possibly going to be seen by somebody else. So please be aware of that. And if you have any confidential questions, then please do come into the Click Meeting room and you can ask them there and they will not be shared. Either way, James will answer them to the best of his capabilities, which is variable at best, but James, good afternoon. Welcome. Thank you very much for joining us.
He's ignoring you. He's in a huff.
I'm having a thought. Yes.
So I know the chief has a couple of questions, so I'm going to hand over to you. And
thanks, Robert. Thank you so much. Hello again, James. And hello, everybody. And thank you for joining us. It's nice that you're all coming in to join in on these sessions. It's great. Now, James, I'm going to kick off with just a couple of things. They're not really. There's no definitive answers. One question is really your take that I'm looking for, and the second one is really to let you know something that came out and something that I haven't had a chance to tell you about, which all happened very quickly, and just your take on it. So firstly, James, as you know, we're all in lockdown. Edinburgh is actually, you probably didn't know this, Edinburgh's been in lockdown since the 9th of October. And we've been in lockdown since then. It's pretty dire here and people are pretty low and fed up. But I was speaking to one or two of the other herpetologists, James, and it's just getting their take on it because we don't always get the facts, as you know, us humble people at home. The numbers are apparently going up, although they may be on the turn. But James, do you have any thoughts as to why the numbers increased at the back end of last year and over these last few weeks?
I don't have any specific knowledge, and my prejudices are probably no more or less valid than anybody else. My guess is that there are a number of factors involved. I think one factor is the new strain, a virus that came seemed to imply it was much more infectious, and therefore and one estimate was it would put up the R value, i.e. the number of people that any one individual would affect. It put it up by about 0.3 or 0.4, which is a major increase. So I think there may have been a change in the virus that made it much more spreadable. I also think that people then, as now, are getting very fed up, and understandably. And my prejudice is a lot of the spread is by people not keeping the social distances when they go out in public or getting together in private. I think people, and where we live in Gloucestershire, it's a small town. We have very low rates. People are very careful. So we went for a walk this morning, and everybody will go out of their way to keep the 2 meter distance when you're passing them in the street. Somebody will step into the road. Now, you can do that in the place where we live, but you can't do that in London. You can't do that in Edinburgh or any of the big cities. There are just too many people on the pavement. Then you get the people who ignore the rules and will get together. And I think those are another good place for spreading. So I think if people really were to follow the 3 key messages of space, mask, and hand washing, I think we'd have seen a smaller peak. But it's interesting, as you know, the figures nationally are the number of people being diagnosed is falling over the last few days, we're still seeing horrific number of deaths. We're still seeing the number of people being admitted to hospital maybe starting to decline. But you have to remember that from infection to hospitalization is at least 1 week, from hospitalization to death, maybe 2 or 3 weeks. So the hospitals really are under huge pressures at the moment. And talking to my colleagues in different parts of the world, we see that. So to go back to your question, we are seeing a much bigger peak now. I think it's probably primarily the virus that's been mutating, which all viruses do, and coronaviruses do well. But also people are not observing the rules. We got complacent. It won't happen to me. Then we had Christmas and New Year, although I think it's a relatively minor effect. Just remember that some woman said, I'll see my granny for Christmas. I'll go to my granny for Christmas, and I'll go to her in December, and I'll go to her funeral in January. And I think that's something we need to be aware of. So that's my take on it. But as I say, it's not robustly supported by data.
No, it's important to hear. I've been speaking to 2 other doctors, one in Wales and one in your area over the last few weeks, and they're finding it tough working on the cold face, and it's a wee bit soul destroying, and they're saying the same. There's a number of things happening out there. Interestingly, James, I was in Edinburgh yesterday in the car, and people are walking on the roads. It's not, Edinburgh is closed down. There's not a lot of people around. But what I did notice were a lot more people wearing masks outdoors than what there ever have been.
Yeah.
I've noticed that. So obviously, our numbers are coming down now, but we've never had it really seriously bad. We seem to be one of the compliant places, or more compliant, shall we say. Thank you. I just wanted to, and so really it's just the same message over and over again, isn't it? And maybe people should be keeping more of a distance, but I'm told some supermarkets are very good at doing that and some aren't.
I'm still seeing some shops, people are going in without masks. Now, they may have medical exemptions, I suspect some do. But I think there's a lot of, but certainly I know in my own hospital, ITU occupancy is the highest it's been. A lot of my liver colleagues are being drafted into work on the intensive care units. And so I'm having to do, and I see that because I'm doing more outpatient clinics because they're taken off the routine work. We are, we're looking at the death rates, but I think we are coming into spring soon. That will reduce spread as it warms up, and particularly immunization, I think, again,
yeah, absolutely,
have a major effect. And it's nice to see the UK is at the forefront of that.
Yeah,
it's really going well.
Yeah, there is a 4th one from Scotland I read at the weekend. Obviously, it's not licensed or anything at the moment, but it's meant to be better than others. They say, but who knows? Who knows? But yeah, I think that's right. Get rolling on with the vaccine. And just to give you cheer, the daffies are coming up in the garden. The snowdrops as little shoots. So it's it's that light that I keep telling everybody about. The other thing I wanted to mention to you, James, and there's some people in today won't know about this, but what came up in conversation last week was people are turning their attention, to better gut health, and particularly, reading people like Dr. Tim Spector, I think his name, from King's, and just, things that people are, not just people with PBC, but anyway, one of the people that was in on our sessions had said that she adopted very much his way of eating, and she played around with it to suit her own diet, and her itch completely stopped. She had to work away from home for a few weeks. She went away, she couldn't eat the way she normally did, the itch came back, etc., etc. And we're hearing this. So when she said that, quite a few other people also said the same thing, as we've also heard about the itch and sugar and chocolate. People are raising that. That came up in the conversation as well. So Professor Jones, David Jones, was with us last week, and so the question came up about gut. And he was very interested in what people were saying, and said, yes, there is a relation. I'm not sure if that's particularly your field, James, but he has offered to do a session on gut, which we've got provisional date in the diary for February, which is fantastic, because anything, improves people's eating habits and gets them off processed food. Brilliant, that's excellent. But is there anything, have you ever come across anybody saying to you, I stopped eating this or I started eating that, and that improved their bowels or their itch or any of those things?
Yes, I mean, it's interesting. I mean, in my clinic this week, indeed, there's one lady who said that when she started taking milky coffee, the itch, she couldn't get on with Questran, with cholestyramine, and she noticed that when she had milky coffee, she no longer had itch. Now, I don't understand. One can postulate several mechanisms for that.
Yeah.
And one of the things I was going to raise today, we do hear these anecdotes, and with something like itch, it is so subjective. I mean, if you say you've got itch, I am in no way to say yes, I agree, or no, you or disagree, because only that person knows they got itch. But it would be very nice if perhaps the foundation could do a call for people who've noticed how changing the diet either increases the itch or decreases the itch, and we could see if there's any pattern, and also find out if there are people, other people who've had milky coffee and it makes no difference. So, I mean, we do get these anecdotes, they're not collated, and I think maybe the foundation would be a very good position to, we'd have to think the questions we asked. But it would be very nice to see if there is a common pattern there amongst the patients, amongst the people with PBC, to see what works, what doesn't work. And that will tell us more about the itch. It will tell us more about treatment. I think going back to diet, I think that there are two things I'd say is that certainly what people eat does affect how they feel, whether or not they've got PBC. There are some true allergies, like celiac disease, which is a very clear condition which is diagnosed medically, and so forth. There are allergies like to shellfish, to strawberries, and so on. These are true allergies. There's another large group where people find certain foods upset them. So there are many people who do not have celiac who like to go on a gluten-free diet because it makes them feel better. And provided the diet is sensible and balanced, there's nothing wrong with that. With PBC, particularly, you may have some intolerance to particular fats because your pancreas may be secreting less, because your medication may interact with how you feel. And therefore, trying diets, see what upsets you, what helps you, is very much the thing to do. And that's a very subjective thing to do. It can be taken, like everything else, to extremes. I had one patient who did not have celiac disease, but was so concerned about gluten that when she had some, I think, halloumi, which was put next to a fish finger that was coated in batter, she said, I can't eat the halloumi. I think that's probably a slight exaggeration. But again, it does no harm. It reduces your intake. Another thing I'd say is that we are very much aware that the bacteria in your gut, what is known as the microbiome, can affect your many aspects. And we know, for example, that you can take mice, genetically obese mice, change the bacteria in their bowel, and they will become thin, and vice versa. That's given rise to the so-called fecal transplants, which is a bad term, but basically you're taking, to use a medical term, shit from one patient and giving it to another. So you can either give it rectally or you can give it by tube. People don't like taking it by mouth for understandable reasons. And the one indication where that does work long term is people who have C. difficile diarrhea, which doesn't respond to medical treatment. That works very effectively. It does seem to have some transient effect in a number of other medical conditions, and it may help people lose weight if they have the right transplant, if you will. But the reality is that they're probably transient, and from what I've seen of the evidence, that fecal transplants at the moment aren't likely to be used widely as an aid to losing weight. But again, sorry to go on about this, but
no,
if certainly there's a vogue amongst obstetricians and pediatricians that so if you have, when the baby is born vaginally, if you think about it, the first thing it sees as it comes out is its mother's backside. And it gets colonized very quickly, starting from then with the mother's fecal bacteria. And that is normal, it's healthy, it's good for the baby. And certainly in animal experiments, those animals that are kept in a totally sterile environment where they have no bugs in their bowel, they thrive very badly. So it's a good thing to do. And that may be partly why obesity tends to run, or thinness tends to run in the family, because you get the fecal colonization from the mother. And there's some neonatal doctors who, if a baby is born through the sunroof, as it were, by cesarean section, will smear a little bit of the mother's feces on the baby to try and get the colonization, which is beneficial for the baby. So I think the bowel does have a significant influence on health and symptomatology. I do think we ought to look at the PBC Foundation, perhaps collating people's anecdotes and seeing if we can draw any conclusions from that. And I would advise people to try different diets. You know, again, common sense. But if things make you feel better, you know, if avoiding chocolate makes you feel better, which I find hard to believe, then just avoid it. It's no big deal. And if things, conversely, if you feel worse, you can go on these exclusion diets where you have very low interactive foods such as rice and boiled lamb, and then you can build up from there. But you do that in extreme cases. But it's worth experimenting. Look at what you eat, and if you feel worse off on something, well, just avoid it. But if it affects your itch, I'd have thought, and again, perhaps you and Robert and I can talk about this later on. We can ask for a formal report from people for their experiences and see if there's any lessons to be learned and advice we can pass back on to to our members.
Yeah, I have. So the people that have spoken, I've asked them, first of all, to write in and let us know at the foundation so we can share the information with people who don't have tablets and computers. And that's, you know, predominantly some of our elder members, just to share it. It may be helpful, it may not. So, and we were going to put something on our website, but yes, I do want to pursue this. I mean, I've heard bits over the piece the last little while, but I really do. And again, this is the advantage of having the app, is that we can collate this information really quite effectively, quite quickly, if we put the questions together. So yes, I would very much like to do that. So I think it's the 23rd of February that we've got. It's not a Thursday. Professor Jones can't do that particular Thursday. So I think it's the 23rd, I'm not sure what day of the week, maybe a Tuesday or Wednesday. However, so we're going to go ahead with that. But yes, I think we should chat about that more. And if anybody out there, if you're finding that something helps or doesn't help, or you think makes the itch or anything worse, then please write in and tell us. Give us a start. Give us something to think about. More than happy, just email or whatever, or write to us by post. We still get lots of snail mail. We'd be delighted to hear from you. So thanks for that, James. That's great. I'm delighted to hear that. And hello to the person in County Derry, Northern Ireland, who just came in there. Okay, right. Thank you, Robert. Over to you.
No, that was helpful. So thank you both. So while we're on the subject of the app, I just wanted to highlight that the BSG conference starts today, which is BSG Campus, which is the British Society of Gastroenterologists, and we are sharing a poster about unmet need in patient care in PBC. So just to highlight that, and that poster is anonymized data, which is taken from the app, so that everybody who's answering our surveys is actually contributing to this. And what you're doing is you're leading to changes in practice, changes in clinicians' approaches and thinking, and highlighting the unmet need in PBC and what can be done to improve it. So thank you to everyone who's involved in that. And I just wanted to share with you that good news. So
excellent. Well done. That's what they need. We need to tell them, and they're going to listen.
Indeed. So, okay, so I've got a couple of questions for you, James, and the questions are starting to come in, which is great. So my first question, so we have somebody in the UK who's been told their AMA M2 score is 42, and they have an ALK phos of 85. Now, they've been told, and I'm looking for the question so I can use their blood tests have suggested that you may have PBC. So I guess she's just a little confused, looking for some clarification. So is there anything you can offer in terms of what's required for a clear diagnosis and where she would maybe go next with which questions?
Right. I think the significance of AMA positivity with normal liver tests is one that we've just talked about a lot because we're not certain. The evidence from an early study 20 or so years ago from Oliver James at Newcastle suggests that many of the people with AMA positivity will go on to develop classical PBC. He did do liver biopsies in people with normal liver tests and AMA positivity, and the majority of them showed histological features, that's features on liver biopsy of PBC. And therefore, the question is, do you call these people, say they have PBC or they have pre-PBC? My own feeling is that they are a very early part of the PBC spectrum. They will go on to develop PBC if they live long enough, and that may be to live to 150 or 200. I don't think a biopsy is helpful. And we've always been a little bit reluctant to label them as PBC because in the days, particularly when the C was cirrhosis, people, again, it had major impact on employment, insurance, mortgage, and so on and so forth. Do you treat those people with AMA positivity? The general view, I think, is not. You wait till the liver tests become abnormal. The fact that ERSO is very benign means that some people do treat them, but there's no hard evidence either way that that's going to make any difference. And I think to label this as pre-PBC is probably better. I've certainly looked after people who presented with abnormal liver tests, AMA positivity, and then it all goes away. So that's the thing. Now, if your liver tests are abnormal, now again, different labs have different normal ranges, so I can't talk to the individual. But if I'd like to know is the alkaline phosphatase raised, and also is the gamma GT raised? If the alk phos is raised and not the gamma GT, then it will suggest that it's not a liver origin. If the alk phos is raised, then I think it's, which 140 probably is, but it depends on the lab, then I would consider they probably do have features of PBC. Whether you want to give somebody a label of that and offer treatment, I think is a very much an individual situation, but it's that borderline area, AMA of 40 units. Again, it depends on the normal ranges. 42 is just outside the normal range. Alkaline phos is just outside the normal range. My guess is they may well have PBC, but I don't know the clinical details. And the question is really, I think, not so much whether you have PBC or not, but whether you have the symptoms that need treatment, whether you should be offered treatment with URSO, and that is a separate question. Diagnosing is important, but primarily it's important because it affects treatment. So my feeling is it might well be PBC, but again, one would need to know more clinical details.
Okay, thank you. And in terms of any questions that somebody's in this situation, what would be the best questions to ask their consultant?
What is the normal range? What is your suggestion for further management? Will you repeat the tests? And if so, when? Do you think treatment with URSO is appropriate? Those are the sort of questions I'd want to ask. Yeah, and again, whether they have symptoms like lethargy, like itching, like Sika syndrome, whether they're on any medication that might, give results.
Perfect, thank you. And again, for anyone who's new in today for the first time, Sika syndrome, how would you define that, please, James?
That's dry eyes, dry mouth. Technically, if you're going to diagnose it, the dry eyes, there are various physical ways like measuring the amount of tear production by putting a little bit of slip of paper, litmus type paper, and measuring the flow, measuring the saliva, but usually it's done on symptoms. Okay. So if you have, but some people have dry eyes because they wear contact lenses, and it's not Sika.
Yeah. Okay, with you. Wonderful. Thank you, Chief. Any thoughts?
No, I think you've covered that really quite well. But if you do have dry eyes and dry mouth, we can talk you through some things that would help. So we do it almost every week, and I won't again today because we spent a lot of time on other things. But if we can, if you want to phone in, we can chat about that.
That's helpful. Brilliant. Thank you. So we've got somebody with PBC who is keen to get the COVID vaccination. So they're due in tomorrow for the vaccination. They woke up yesterday dizzy and nauseous, which is a fairly regular occurrence for them. It's something that they have when their condition flares. So they're asking, do they think that we're still okay to get the vaccination because they're keen not to delay that? So any thoughts?
I think if they've gotten how old did you say they were? Sorry.
Oh, I didn't. Quite old. Definitely the Chief's age.
Oh, that old.
She doesn't like the pot, is there?
I think if you're feeling unwell at the time, sometimes it's better just if you can defer for a few days the vaccine, because then you won't know if it's a side effect of the vaccine or the illness. And on the whole, if people are acutely unwell, then one would defer the vaccine. But again, if you consider, and thank you for sending that reference to D'Amica paper we can talk about in a minute. Okay. With all interventions, you have to weigh up the risks and the benefits, and you just need to look at the mortality of. It's still, if you get COVID, even if you're 75, I'm not looking at Collette here.
I should bloody say so.
Because I'm older than she is.
Much.
and age and maturity. But there's still, even if you go to ITU, there's a 50% chance of death, a 50% chance of survival. But the long-term effects of COVID, and I think there are potential risks with COVID vaccination, but we've seen worldwide trivial amounts. Yes, it's not been fully tested in people with immunosuppression, with people with liver disease and so on. But I think to deny access to vaccination for COVID on grounds of theory, we don't know what happens. Again, it's an individual choice and the individual must make up his or her mind. But it seems to me we know there's a serious risk of death with COVID, and there's no real evidence, there's no evidence that COVID vaccination is harmful, whether you've got liver disease or you're on immunosuppression.
Perfect. Okay, thank you. Chief, any thoughts on that before I move on?
No, I mean, people, what we put up on our website last week was excellent. We had other support groups, liver support, contacting us to say, could they put it on their site, which of course we said, yes, please do. And we had 1 or 2 emails from people saying, there were rather terse emails as to why they wouldn't have the vaccine. And I just want to say to everybody, we're not telling you to have the vaccine. We're just telling you as much as we know about the vaccine. On our website, you want the information. We give you the best that we can possibly get. But James is absolutely correct. It's very much an individual choice. And we can't say it's right or wrong. It's your decision.
Yeah, I mean, we wear seatbelts in cars. All right, it's a legal obligation. And yes, you get seatbelt injuries. And if you don't wear your seatbelt, you won't get a seatbelt injury. But equally, you won't get killed or maimed by having your head smashed through the windscreen.
Yeah. Oh, something cheery now, please.
Okay, so James, I did send you a link just to ask you about it. Are you happy for me to?
Absolutely, please do. Yeah, it's good to raise it.
Okay, so it's not a question, but I'm just raising awareness. There was an article that was shared, so we became aware of it through Twitter. So this is about the SARS-CoV-2 vaccination in IBD. Now, we know that some people with PBC do have either IBD or colitis or those kind of conditions. Now, the outline of the abstract is that there are more pros than cons. So I guess I just wanted to highlight that. And I guess just to again ask you if you had any thoughts on that, or if you had a chance to share any information along those lines.
Right. I think they make a point that in the clinical trials of COVID vaccination, a number of groups were intentionally excluded, and people with an IBD in this case is inflammatory bowel disease, not irritable bowel disease, which is a huge difference. And this applies also to other groups like people who've had immunosuppression, people with advanced liver disease and so on. They are intentionally excluded. And therefore, they do make a valid point that these vaccines have not been formally tested in large numbers of, or indeed in small numbers of people with a number of chronic conditions. And that is absolutely right and correct, and I wouldn't dispute that. The next question comes is, would you exclude treatment because it's not been tested? And again, you come back to the risk-benefit argument. Are there theoretical risks why it might be of harm? If it were a live vaccine that you're getting, yes, there are risks that it would harm. But with both the Pfizer and the Moderna vaccines, which are RNA, and the Oxford vaccine, which is a non-replicating adenovirus, theoretically the risks are very, very small. The potential benefits are very great. And going through the risk-benefit equation, I think most, if not all, experts and doctors would advise people to take the vaccine. But it's advice, it's not obligatory. We know that other vaccines can have side effects, and it would be naive and wrong to say the vaccine is entirely safe. We don't know that. But so far, and that's why for most vaccination programs, from the trials to rollout, maybe 10 years or more. But because of the way the coronavirus is affecting people's physical lives, people's mental lives, people's financial lives, people's social lives, they felt, on the evidence of thousands of patients, early side effects were trivial and short-term, like maybe fever, maybe an ache, and no adverse effects of note were noted. Does it mean in 5 years' time we might find problems? Yes, it does mean that might happen. But we know people are dying now. And I think if the government or the health watchdog said, well, we don't know it's entirely safe, we need to wait 20 years, I think quite rightly there'd be uproar. So they do make a point, we don't know, but there's no evidence. And so far, many units, I know our own program in Birmingham, I know the Oxford Renal program, they're rushing to advise their recipients to have vaccine, and I'm not aware of any adverse event. So yes, theoretically, there is uncertainty. Yes, one has to be cautious, but the advice emphatically is to take the vaccine when offered, but that's the advice, not the instruction.
Yeah. Okay. Perfect. That's helpful. Thank you very much. Chief, any thoughts?
I don't know to say this or not, but I'm going to say it's in my mind. While you were chatting there, I got an alarm on my phone and I got a message from one of our members who's a 50-year-old nurse who's desperately, desperately ill in hospital with COVID. And I had written to her and she just messaged me to say her dad read the letter out over the phone. And she's explaining in detail how ill she feels and what various things is happening to her. And I just reading that message, and if anybody out there is listening, and if you're not conforming to the rules, please do. Please. I'm just saddened when I read these things, and we all have to pull in together. I think, James, we hear lots of people talking about how it was in the war and if it was camaraderie and people sitting in the underground and singing songs, which is fantastic. They had no idea that they had 6 years of suffering. But with this, I suppose we're not together, we're in our own homes, we're not communicating that well or as much, and egging each other on and giving each other support. And I think people are missing that bit, and hence some of the rule breaking. But I just hope these things make people think a bit longer and deeper.
I would remind people that they look back on those wartime years with a certain rose-tinted spectacles. And although I was born at the time of rationing, I was not born during the war or indeed conceived during the war. But if you actually look at the figures, murder rates, thefts actually went up during the war time. And yes, it may, you do hear an awful lot of good. When I went out on my walk this morning, we shouted across the road, and a neighbour was passing. They've got 110 people she was going to plant bulbs for, to give some spring plants for people who are socialised. We do see an awful lot of people working very hard to support others, and I think the gloom and doom of the BBC particularly doesn't really highlight that enough. So I think there's a lot of good stuff out there. It is a shit life for most people, and an ultra shit life for quite a significant number. But there's a lot of good. And again, I remind you that that phrase, you know, if I see my granny if I see my granny in December for Christmas, I'll see her for a funeral in January. And we just have to grit our teeth for a bit longer. Things are a lot better than they were in the war. Although numbers are high, the young people being maimed is not happening. We have Zoom, we have similar ones. We can have some contact, but it's not like seeing the person.
No.
Okay, thank you both. I'm going to come back onto PBC now. So we've got somebody who has PBC who has pain on a regular basis. So they've been asked to consider gabapentin. So again, if you can talk about gabapentin, that'd be great. But also, can we open up the conversation to pain control and analgesia in PBC, please?
It's a difficult one. Obviously, with pain, the first thing, there are two aspects. One is, why has the person got pain? What's the cause? Is it something that heralds a condition that needs treatment? So you need to know, why has the person got pain? And that is often very difficult. Pain is very subjective, and individual pain varies. Again, as in itch, only the individual can say whether they have pain and whether they have severe pain and how it affects their life. The psychology of pain is very interesting. And the example I was given as a medical student is, if you think of the pain inflicted when a hockey stick meets your shin. If you're playing hockey, you're running around, getting terribly excited. You come back afterwards, you notice bruises on your shins. How did it happen? I can't remember. If, on the other hand, I said, look, at 3 o'clock now, I'm going to hit you on the shins with a hockey stick. Oh, it's 10 to 3 now. Could you stand on the, could you stand up? And then I'll bring in a few people to watch you. You'd be in pain before I even whacked you. So the stimulus is the same, but the pain felt is quite different. So I think one's got to bear that in mind. And that's not, and we also see, for example, again, looking at war wounds, that people who have their arm blown off for several minutes or even a few hours don't notice any pain. It's remarkable. So there's a physical cause, there's a psychological cause, and the treatment. The thing about treatment is, the only way you know what works is to try various treatments. Analgesia doesn't work in the pot or in the packet. You have to take it. Suffering pain doesn't ennoble the soul. It makes you just bad-tempered and difficult to live with. So take enough painkiller to be effective. And what works for one person may not work for another. And what works over one time may not work after. And you always need to titrate the pain relief, both in type and frequency, to the individual. That said, there are the straightforward and again, this is not really my specialist area, but there are the painkillers, and of course the common two types are the non-steroidal anti-inflammatories like Prof and so on, and aspirin, and then the paracetamol. In liver disease, paracetamol is usually very well tolerated, up to 6 tablets, 3 grams, or even 8 tablets a day. People are often anxious because it's an overdose, that paracetamol can be toxic to the liver, but that's an overdose. But if you take 6 tablets a day, certainly your liver will tolerate that. We tend to be careful about non-steroidal anti-inflammatories such as Prof and so on, because they can interact with your body in liver disease. They are more likely to cause gastritis. They can interfere with your kidneys and put you into kidney failure. So we try and avoid those. Topically, non-steroidal creams are probably safe, but they don't work in all. Then there are physical treatments, heat, cold, and again, physiotherapists you can be excellent, particularly if it's musculoskeletal. And as we've said before on these meetings, they're often an unused and unappreciated source of pain relief. Heat, cold, ultrasound, and so on. They have many tricks up their sleeve. If those things don't work, then you're moving on to the stronger painkillers like codeine, cocodamol, and so on. They are much more concerning because they are good pain relief, but addiction is a huge problem. They can also cause psychosis. They can also make you feel unwell with nausea, and in PBC they can cause itching. So paracetamol is the first line. Topical treatments, physical treatments shouldn't be ignored. And then you're getting on, depending on the liver disease stage, whether you're going to try the Brufens or not. If you try them, you've got to be carefully monitored. And otherwise you go on to those more potent drugs, which have many more side effects, and addiction is a very, very real problem.
Yeah.
Then you have the drugs like pregabalin, which act as a sort of modulator. And there are two types. There's pregabalin, which is, for me, the second line. The one I would go to first is amitriptyline. Now, amitriptyline used to be used very much as an antidepressant, and it was quite a good antidepressant. But it's succeeded now by a lot more effective ones like Prozac and so on. At low doses, amitriptyline is very good at helping pain relief. Here you're talking about 10 or 20 milligrams a day, whereas the dose that you use to treat depression would be 200, 250 to 300. So it's not, people get very upset because you think you're saying you're depressed, blah, 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 and I'm treating your depression. So amitriptyline is the first line, and that helps many. And then pregabalin and its sister drugs can be very effective, but they do cause somnolence. They do have side effects. But again, they're worth considering. Finally, people with chronic pain do get depressed. Inevitably, if your life is limited by pain, it's inevitable you're going to get depressed, and recognition of that and treatment of it, to me, makes good sense. Whether you do it by talking therapies such as CBT or antidepressant medication depends on the severity in the individual. But I think it's often forgotten that it's not that depression causes the pain, it's the other way around. But don't ignore the depression. Think about how bad it is, whether it merits intervention, and if so, what sort of intervention. So that's and if you can't really control the pain, again, you can go for nerve blocks, anesthetic injections, but then you really need to see a proper pain specialist. And it's a matter of balancing the pain with the side effects of the treatment, learning to live with it. But it can be a really difficult time for people. And as I say, side effects, particularly with the stronger painkillers, and we're seeing in the States, the dihydrocodeine pandemic, which now isn't causing as many deaths as the COVID, but until recently was. And this is one of the perils of private practice. I think DF118 will cure my pain. Will you prescribe it? No. So you go to another doctor who will, and because you get paid if you prescribe it, it's inevitable, etc. But that little rant aside, chronic pain, but find out the cause, and there's a ladder of treatment. But if it starts escalating, you're not in pain, then you need to see a proper pain specialist. And it is a challenge, and it can ruin people's lives, quality-wise, and their families, indeed.
Okay,
So
thank you very much.
I would like to add to that. I mean, you did steal my thunder with the physiotherapy, who I think are the best. I think they're even more cleverer than hepatologists. I have to tell you, I think they're fantastic and they're underused. But I think sometimes that we don't realise we can do things for ourselves, and the pain, as you say, is absolutely subjective. You know, whether it's arthritic pain or whatever type of pain you have, you know, as you said, hot baths, ice packs, movement. You know, please, if you're in pain, don't just be sitting thinking, oh, I can't move my hands, they're so sore, I've got to keep them still. Please don't do that. Please, I mean, give us a ring and we can talk you through. There's various things you can try, but movement does help. Joint pain, it absolutely helps joint pain. And as James says, physiotherapy. But there are things, and sometimes Granny's old remedies do help. The heat or steam inhalation or ice packs, whatever, or even a combination of both. There's most of the time you can get some relief in some way. So please do contact us if you feel you're not getting very far, and let's see what we can do.
All right, brilliant. Thank you both. Just before I move on, I wasn't entirely clear, and if I've missed something, I apologize. Which class does gabapentin sit in?
Pharmacologically, I'm not sure I can give you the correct answer to that without cheating.
Okay, but because you spoke about NSAIDs, you talked about the kind of amitriptyline. So I just, you know, again, because the question was, you know, somebody had been advised with gabapentin, and they wanted to check that that was okay within their PBC, I guess. So I just wanted to double check if you knew.
No, it's not an analgesic as such, but it helps. It used to be, interestingly, an anticonvulsant drug, and it's a GABA analog, if that makes more sense to you than it does to me. But gabapentin, as they was used to treat convulsions and what's called neuropathic pain. So it acts centrally. And the sort of times where one's particularly using it is things like post-herpetic neuralgia, when you've had herpes rash, diabetic neuropathy. It works quite well in alcoholic neuropathy. So in the neurological causes of pain, but it's not an analgesic as such.
Okay.
But acts more centrally.
Just another small instance. My dog had it for a slip disc, and it was she did.
Yeah, no, it's used in animals, and interestingly, animal drugs for animals are usually more expensive than they are for humans.
Funny you should say that. Yeah. Anyway.
Okay, thank you. So aware of time, so I've got a couple of questions I'd like to squeeze in if at all possible.
Yeah.
So we're in the kind of quick fire round. If you've had hepatitis previously, can that raise your AMA?
No.
Okay.
If it's viral hepatitis you're talking about.
Yes, it is.
No.
Okay, perfect. Thank you. Any thoughts on probiotics or herbal therapies with PBC, please? And I'm glad I put that in the quick fire round.
So the probiotics, remember the probiotics, we're going to be covering that with the gut, aren't we?
Yeah, but herbal remedies, again, because they're herbal, doesn't mean they're safe, and equally doesn't mean they're ineffective. And as one person said, if you think herbal remedies are ineffective, take a dozen Senecot and come back tomorrow and tell me they're ineffective. But there's no good evidence that they make a big difference. But if you find that symptomatically they help, then by all means use them. But and probiotics likewise, if you find they help. But there's no evidence that they make a lot of difference. Equally, things like milk thistle and so on, much loved on the continent, don't really have a major impact.
They say in Scotland and New Year there's no milk thistle to be had. They say.
Because it's a good way if you think that I can drink, a bottle of whiskey and then have milk thistle, it'll cancel each other out. It's like saying a Mars bar and a Diet Coke cancel each other out.
Okay, Perfect. Thank you. Now, I've got a question for you. So this is going back to the vaccine again. So it says that bearing in mind that we don't know the long-term issues from the vaccine, would an option to be taking chloroquine, if I pronounced that correctly, and zinc, would that be safer?
No.
Okay, perfect. Okay. I'm glad we went into the quick part round because that is a question. So, okay, so I'm going to double check on Facebook if there is anything. No, there's no questions in the room as well. So I'm going to say thank you to everyone who participated today. Thank you very much for your questions. Lots of comments in the comment section on Facebook. Again, reinforcing with experience what James is saying. So that's great. So thank you very much for that. And Chief, I'm going to hand over to you. So thank you, James.
Thank you,
Chief.
James. Thank you. It was very entertaining, very knowledgeable. And I'm sorry I hit you those the gut thing unexpectedly, but I just don't have time. So maybe we will organise that chat. I think it's very, very interesting, and I'm keen to know more. Thank you, everybody, for your questions. We've got nice messages coming in. And I would say to you, if you can, many, many, many thanks, James, Collette and James from Syria. Please if you can, go onto our website, and if you can donate. I've just got a bill in this morning that all these sessions that we do, they do cost us money. We are in another session. I'm very, very keen to keep this foundation going because you need it, we need it. So if you could do that, I'd be very, very grateful. Even if it's the price of a cup of coffee, or you can do more, then be grateful if you can. Well, there we are. Thank you for joining us. So James, thank you again. I think Alan. Oh, sorry. Go on.
So if I can just say one thing, if you have any experience of altering the diet affecting your itching, please don't write in now, because I think what we need to do is we need to think how we want people to respond. We need to do it in a structured way,
okay,
so that when we get hopefully loads of comments, we can analyze them properly. So if you agree, Collette, Robert, don't do anything now, but we'll try and put a sort of little mini questionnaire together so that we can get it properly considered and use the app. Would be a very good way of doing it.
Yeah, let's do that, Robert.
So I'm going to add on to what James has said. Other than not doing anything now, what we would ask you to do is make sure you've got the app.
Yeah.
So make sure that you know your username, your password, make sure that you've got into the app and that you're using it. And then, we can get you up and running so that you're used to the app, that you're comfortable with it. So when we do ask your questions, that you can be involved in the conversation and you can help take forward the cause. So that's
good. So can you raise this, and I'll do it as well, Robert, in the 4 o'clock sessions? Can we keep the app going and explain why? Because there's different people coming into different sessions.
And use of the app is free to the user. Although it costs the charity money, so please pay, but it won't cost you to use the app. It's absolutely free.
That's right. So if you can afford it, please do. But in the meantime, I think Alan's waiting to hear from you, James, about more dates and various bits.
I did respond to him.
Oh, you did, right? Okay. We've got Andy Yeoman fixed up for March. He's in clinics and things. Yeah. So thank you, Robert. That was great. And we forgot James. Keep well, and thank you, everybody, so much. And we'll speak soon. Bye for now.
Take care. Thank you.
Take care, everybody.